So it's before 1921, the diabetes was considered to be inconsistent with the successful pregnancy. So no, you know what was happened in 1921. So that is the year where an orthopedic surgeon Banting, with the help of the medical student Best, discovered one of the important molecules in the medical field, that is insulin. So after the discovery of the insulin, a lot of changes have occurred in the management of the diabetes. So before the insulin, there was no treatment for the diabetes, and a lot of the people with the diabetes, they used to die within a short period, maybe less than 6 months, with DKA or with pneumonias or with gastroenteritis or with infections, etc. So after the insulin era, so definitely the changes of the diabetes management have changed a lot, and now we are seeing very successful pregnancy outcomes, big thanks to the insulin and the Banting and the Best. So pregnancy in the untreated diabetes was almost unknown at that time. The true diabetes was inconsistent with the conception, a statement probably prompted by the short lifespan of the women with the type 1 diabetes. Usually the type 1 diabetes occurs less than the 20 years of the age group. So before they get pregnancy, and with the pregnancy and the diabetes, and after the type 1 diabetes, so definitely it is not at all successful without any insulin management. And abortions and IUDs are also very quite frequent in the diabetes background. And the risk was the death of the mother during or soon after the pregnancy due to the uncontrolled diabetes, maybe because of the diabetic ketoacidosis, and overall the mortality was also high in that era. So we should remember some of the few figures, notable people who have done a lot of work on the diabetes and for the clear-cut understanding of the pathophysiology of the diabetes. She is Priscilla White, the doyen of the diabetic pregnancy, identified the link between the diabetes duration, vascular complications, and outcomes in the pre-existing diabetes complicating the pregnancy. So introduces the world famous White classification of the diabetes in pregnancy way back in 49. So this classification didn't include a GDM as a separate entity until the 1980. See, the first case of the GDM was reported by the Benowitz in Germany, German physician, in 1853. He considered diabetes a symptom of the pregnancy and noted that glycosuria resolved after the delivery. So at that time they thought that there is only incompliance with the pregnancy, and the concept itself is relatively recent. So these are the several people, and the most notable person here is the Sullivan. So O. Sullivan introduced the term GDM. And of course, you all know that O. Sullivan and the Mahan's criteria, and then the modified by the Carpenter and the Couston. At a later time, we will go into these things. And he is the important person that Frankel introduced the terms of the facilitated anabolism and the accelerated starvation. So I will tell you what is facilitated anabolism and accelerated starvation at a later time. So the WHO criteria was the diagnosis of the GDM was introduced in 1999. And DIPSI guidelines were published in 2006, big thanks to Professor Sashaya from Chennai. So he made the guidelines for the pregnancy-induced diabetes in Indian population. So you all know that the DIPSI criteria, 75 grams of the glucose given to the pregnant mother without any relation to their food meal, and wait for the 2 hours and get the blood sugar done. If it is more than the 140, it's a case of the GDM. And other criteria were also there, International Association of the Diabetes Pregnancy Study Group and ADA, etc. And this is the normal criteria in a non-pregnant adults, the diabetes. You have the 4 criteria. One should be present out of these 4 criteria to consider that any person is a diabetic or not, whether they are in the non-pregnant state. So they are the symptoms of the diabetes, like your classical 3 Ps or etc., or asthenia or weakness, etc., with a casual blood sugar glucose concentration, that is your random blood sugar more than the 200. So that is the one criteria. So the symptoms of the diabetes, usually the symptoms of the diabetes are not there in type 2 diabetes. In fact, the commonest symptom in type 2 diabetes is no symptom at all. But mostly the type 1 diabetes people, they have your classical 3 Ps. If the blood sugar, random blood sugar is more than the 200, its symptoms, so it is a one criteria. And the second criteria is the fasting blood sugar. If it is 126 or more than 126, in any person is a diabetic. Why only 126? Depending on your retinopathy changes. So the retinopathy changes starts from the fasting blood sugar more than the 126. So that is how the 126 has came into the number, not 125 or 130. and 2-hour postprandial blood glucose 200, and then the HbA1c more than the 6.5. So these are the 4 criteria one should remember in any person to consider them as a diabetic. So the random blood sugar with symptoms more than 200, fasting blood sugar at 126 or more than that, postprandial blood sugar 200 or more than that, HbA1c 6.5 or more than that, the person has to be considered as a diabetic. At least one out of these 4 criteria should be there, even though they are asymptomatic. So what about the impaired glucose tolerance? See what the criteria I told you, they are the diabetic criteria. And we have the normal population. Between the normal and the diabetic population, there the subset are a very good number of the people are there with the pre-diabetes. So you should remember the normal figures, you should know the diabetic figures, and between these are the pre-diabetes individuals. So here the impaired glucose tolerance, and then the fasting blood glucose between 101 to 125 is the IFG, that is impaired fasting glucose. When the fasting blood sugar is less than 100 or less than the 100, they are the normal. So the fasting normal blood sugar fasting is 100, 101 to 125 is the impaired fasting glucose, otherwise called as the pre-diabetics, and 126 or more than 126 of fasting is a diabetic. In the same way, the impaired glucose tolerance, that is the IGT, is in relation with your postprandial blood sugars. So up to 140 is the normal, 141 to 199 is the IGT, otherwise called as the pre-diabetics, and then more than the 200 is the diabetic individuals. So to consider a pre-diabetic, at least one of the 2 criteria must be there. So the fasting between 101 to 125 is a pre-diabetic, the postprandial 141 to 199 is a pre-diabetic. Am I clear? So the normal fasting less than 100, the normal postprandial less than 140. So in GDM, what is IFG or what is IGT is GDM. Okay, so in a pregnant woman, when the fasting blood sugar is beyond 100, you can consider it as a gestational diabetes. In the same way, the postprandial blood sugar more than 140, you can consider as the gestational diabetes. So these are the definitions, but the targets are the different. You know the target of the GDMs. So the fasting blood sugar should be less than 90 and the postprandial blood sugar less than 120. So 90 and 120 are your targets in the GDM, but to diagnose the GDM, these are the values. So here is a one case study, 28-year-old non-gravid female as an OGTT performed. The fasting blood sugar is 115 and the 2 hours blood sugar is 208. What is our diagnosis? Is it normal, pre-diabetic or diabetic? Excellent, it's a diabetic because the 2 hours postprandial is more than 200. Here it is 208. So whatever the fasting, what is the name, what is the title you give it to this fasting blood sugar? It is pre-diabetic. So once the blood sugar 200, 2 hours is the 208. So you can consider them as a diabetic only, not a pre-diabetic. Suppose here 2 hours is 160. Then what is your diagnosis? Pre-diabetic. Suppose 2 hours blood sugar is 130. What is your diagnosis? Again pre-diabetic, but here it is 115 means it is IFG, that is impaired fasting glucose. Suppose in this case the fasting is 90, whereas the 2 hours blood glucose is 160. So what is your diagnosis? Fasting is 80, here the postprandial is 160. So again pre-diabetic, but not IFG, it is not impaired fasting glucose. Impaired glucose is the fasting glucose is the normal, here IGT. So that is impaired glucose tolerance. So you need to remember IFG, IGT and also diabetic range of your fasting and the postprandial. So what is the diagnosis here? Here the 35-year-old non-gravid female, a strong family history of the diabetes. The 0 hours is 98, fasting is 98, postprandial 177. So what is the diagnosis here? Not a diabetic, but not a normal, a pre-diabetic, normal fasting, but abnormal postprandial. So the name given to this is IGT. So impaired glucose tolerance. See the etiological classification of the diabetes, we have the 4 types of the diabetes in the world. One is the type 1 diabetes. So here the type 1 diabetes is the total beta cell destruction. So there is an insulitis. There is no insulin production from the beta cells. So that is the type 1 diabetes. Here what is the answer for the type 1 diabetes? What is the treatment for the type 1 diabetes? Insulin. How long? Lifelong. So that is the type 1 diabetes. Fortunately, we have the very few cases of the type 1 diabetes in India, but of late the number of the type 1 diabetes is also increasing, maybe because of the viral infections or maybe because of the other reasons, genetic and environmental factors. But In India, the type 2 diabetes is much more common, the second variety. So the type 2 diabetes may range from predominantly insulin resistance with a relative insulin deficiency, whereas the type 1 diabetes is a predominantly insulin deficient. So that is the reason you are giving more and more insulin from the extravenously. Whereas the type 2 diabetes more of the insulin resistance rather than the insulin deficiency. So here you have the some treatments. What are the treatment of the type 2 diabetes? One is the diet, the second one is the exercise or the lifestyle measures like yoga or meditation, etc. And then your OHS, and then your insulins, especially the basal insulin, and then your continuous insulin therapy, that is your basal bolus therapy, etc. So in type 2 diabetes, the answer is not always the insulin. Insulin may be required in the type 2 diabetes to control the blood sugars, whereas insulin is required in type 1 diabetes to survive the patient, to survive the individual. So the insulin is needed for the survival in type 1 diabetes. The insulin is needed to control the hyperglycemia in type 2 diabetes. Even without the insulin also we can survive, the person can survive with type 2 diabetes, not with type 1 diabetes. So these are the other types of the diabetes, like the MODIs, that is listen. This is the genetic defects of the beta cell function, that is the monogenic diabetes is the MODI, and the genetic defects in the insulin action, and disease of the exocrine pancreas, that is your pancreatitis. Say alcoholic pancreatitis or gallbladder pancreatitis, where the pancreas is totally damaged, it's exocrine pancreas, pancreatic disease, and especially in the places of your Tamil Nadu and the lower Andhra Pradesh, and some of the people they present with severe abdominal pain, recurrent abdominal pain or steatorrhea, and the people are very lean. So if you take an X-ray, you will have a beautiful calculi opposite to T12 on the L1 vertebra. So what is your diagnosis? Calculitis, calculus pancreatitis. So that is pancreatic diabetes, fibrocalculus pancreatic diabetes. So in such individuals, there will be also endocrine dysfunction leading to the diabetes. So these people you need to treat with both the exocrine dysfunction as well as the endocrine dysfunction. Exocrine dysfunction with your pancreatic supplementations. And other endocrinopathies like your hypothyroidism is a very risk factor for the type 2 diabetes. Hyperthyroidism, again a risk factor for the diabetes. Antibodies against your thyroid and also antibodies against your insulin structures. And other acromegaly or other diseases like Edison's disease or Cushing's disease. So they are also associated with the type 2 diabetes, but not that common. And drug or chemical induced are very common in Indian population, especially the RMP induced diabetes. What is the commonest drug they used by the RMPs? Steroids. The steroid induced diabetes. It's a very common things. There the answer is withdrawal of the steroid. Withdrawal of the steroid, and most of the people know if they are prone to get the type 2 diabetes, like their strong family history. If you use the steroids for a longer period, and definitely these steroids will cause insulin resistance, and definitely they will turn up into the type 2 diabetes within no time. So the post-COVID era also, we have used a lot of the steroids during the COVID period, and a lot of the people they became the diabetes, especially the type 2 diabetes, with the people with a strong family history of the diabetes. And other drugs like diuretics, they cause hyperglycemia. Beta blockers, they cause hyperglycemia. Steroids will cause hyperglycemia. So there are certain drugs are there. Infections, especially the viral infections, they attack the beta cells, like your Epstein-Barr virus or Hep B or Hep C or HIV. Okay, so these viral infections, they may damage the beta cells to cause the insulitis, and then the insulinopenia, and finally the diabetes. Yes, finally your fourth variety is your gestational diabetes. There are only 4 types of the diabetes in the world: type 1 diabetes, type 2 diabetes, gestational diabetes, and other types of the diabetes where already told. Okay. Now what you mean by the GDM? So it is a glucose intolerance of any severity with onset or first recognition during the pregnancy. So that is the GDM. So the glucose intolerance of any severity, maybe the mild, maybe the moderate, maybe the severe, with onset or first recognition during the pregnancy is the GDM. See here, it is divided into 2 types GDMs. One, a true GDM, which occurs in the second half of the pregnancy. That's how you screen them between the 24 to 28 weeks of the pregnancy. Whereas the diabetes occurring in the first half of the pregnancy is not a gestational diabetes. It is a pre-gestational diabetes. That means that diabetes was recognized or diagnosed first time during the first half of the pregnancy. Maybe unrecognized type 2 diabetes, maybe unrecognized type 1 diabetes, but mostly it is the type 2 diabetes unrecognition rather than the type 1 diabetes unrecognition. Because type 1 diabetes is a symptomatic disease. All the type 1 diabetes, they present with your classical 3Ps. Your polyuria, polyphagia, polydipsia, and unintentional weight loss is a very common in the type 1 diabetes, and it's a short duration of the symptoms, and everyone will be diagnosed with the type 1 diabetes because they are very symptomatic, because not only the 3Ps and also unintentional weight loss. On the other hand, type 2 diabetes is asymptomatic. Sometimes it may be diagnosed during your screening, first antenatal screening, when the blood sugar is 200 or 250. So that means she has been living with the diabetes without knowing that she is having hyperglycemia, and first time detected by you by your screening blood sugar examination. Yes, this definition is applicable irrespective of whether insulin is used or not for the treatment. See, insulin is not the true treatment for the GDMs. See, in the second half of the pregnancy, what is the treatment of the gestational diabetes? A true gestational diabetes? Any question yet? What is the treatment of gestational diabetes? True gestational diabetes. 1, 2, 3. 1 starts with D, second starts with M, 3 starts with I. Diet, exercise, metformin and insulin. So tell me, what is the 3 modes of management of the gestational diabetes? What is number 1 is diet. Number 2, number 3. So partly wrong. Number 1 is diet. Number 2 is diet plus metformin. Number 3 is diet plus metformin plus insulin, and the fourth one is diet plus insulin. See, the diet is very important in gestational diabetes, true gestational diabetes, in the second half of the pregnancy. Whereas if the diabetes is occurring in the first half of the pregnancy, it is a pre-gestational diabetes, where the answer is insulin only. Even no diet, no metformin. They are only the insulin, because the diet, no restrictions for the diet in the first half of the pregnancy, because the mother needs nutrients. The fetus needs the nutrients. So that's how in the first half of the pregnancy we treat only with the insulin, very high intensity insulins. Maybe the 3 shots of the regular insulins before the breakfast, before the lunch, before the dinner, and 1 shot of the basal insulin, maybe your glargine or the itimer or the deglutide at the bedtime, or if the patient is the poor, even INH insulin, like your Insulatard or hum insulin N, etc. at the bedtime. So that's how we treat the pre-gestational diabetes, when the diabetes occurring in the second month of the pregnancy or the third month of the pregnancy. Suppose if the pregnancy is the second half of the pregnancy, and obviously diet for about 10 to 15 days, and then you add the metformin, maybe 250 milligrams OD or the 250 milligrams BD or the 500 milligrams BD or 500 mg TID, and see how the fasting blood sugar less than the 90 and post blood sugar less than the 120, you are happy, okay. Otherwise you can add the insulin, that only 1 shot or 2 shots a day, mostly 4 or 5 units before the breakfast, or maybe 4 or 5 units before the lunch, maximum 10 or 15 or 20 units before the breakfast and before the lunch, in a true diabetes. In a true GDMs, usually we avoid giving the insulin at the bedtime in a true GDM, because the fetus is in the fasting for about 12 to 14 hours, and the fetus needs the maternal glucose for its survival. So that is the reason, if you give the regular insulin or any mixed insulin at the bedtime, so there are chances of having the hypoglycemia in the midnight, and then the fetus won't get the glucose from the mother. So that is the reason in the true gestational diabetes, the fasting blood sugars will be at least 10 to 20 milligrams lesser than the non-pregnant, non-diabetic gravid female. It is also applicable irrespective of whether the condition resolves after the delivery. So most of the diabetes, they resolve after the delivery. That is your true GDM. Whereas the pre-gestational diabetes, they may resolve, they may not resolve. So when treating the diabetes means you are treating the 2 generations, because the mother of this gestational diabetes are more prone to get the type 2 diabetes in the near future. The offspring of the type 2 diabetic gestational diabetes mother is also going to get the diabetes at a younger age group. Not only the diabetes, metabolic syndrome also. What do you mean by metabolic syndrome? A combination of diabetes, hypertension, dyslipidemia, and obesity. So these 4, now this is the modern MS. So earlier MS means mitral stenosis. Now the MS means metabolic syndrome. So now the India is the capital for metabolic syndrome. Most of the people are having type 2 diabetes, hypertension, diabetes, obesity, metabolic syndrome. See, the woman diagnosed with the GDM might have a normal glucose tolerance prior to the pregnancy, becomes abnormal glucose tolerance during the pregnancy, and returns to the normal following the delivery. That is the true GDM. So in the first half of the pregnancy, normal glucose tolerance, your fasting and the PP are the normal. Second half of the pregnancy, the fasting is 100 or 101, and postprandial is 140 or 160 or 200. And then immediately after the delivery, again they are the normal. So that is the true GDM. Now the second group, mild glucose intolerance, the pre-diabetes before the pregnancy, which worsens during the pregnancy. For example, a female aged about 32 years, the obese at the time of the pregnancy, so she got the blood sugar of fasting blood sugar of say 105, and the postpartum blood sugar is 160. Okay, so she is not normal at that time. So looks like a normal 106 or 114 of the fasting and 144 or 160 of the postprandial, but they are pre-diabetics. So pre-diabetics, and later they get the diabetes in the true GDM. That is how some people are like that. And the third group is previously undiagnosed type 2 diabetes. In India, because most of the people know, they go to the doctor only when they are symptomatic. So asymptomatic people, they never go to the doctor. So pregnancy, type 2 diabetes, I told you, the common symptom in type 2 diabetes is no symptom at all. So most of the time you diagnose that undiagnosed type 2 diabetes during your antenatal visits. In the same way, previously undiagnosed type 1 diabetes is a very rare because it's a symptomatic disease. Previously undiagnosed MODY and the secondary diabetes is a big topic. What you mean by the MODY, that is a maturity onset diabetes in young 1 to 7, 8 is also there, and secondary diabetes, and very few cases are there. If you learn the GDM, a true GDM, if you learn the pre-gestational diabetes with type 2 diabetes and the type 1 diabetes, I think 99% of the cases you can manage them. What is the pathogenesis? What is the effect of the pregnancy on the blood glucose? See, the pregnancy is characterized by profound metabolic alterations in the mother. So the pregnancy itself gives a lot of the changes in the metabolism, especially in the carbohydrate metabolism. See, you divide the pregnancy into the first half and the second half. In the first half, the mother gets a lot of the nutrients. They stores the lot of the nutrients for the second half of the pregnancy. Maybe in the form of the carbohydrates, maybe in the form of the amino acids, or mostly in the form of the fat. So you know what you mean by the glycogenesis, and there will be the protein synthesis, and there will be the lipogenesis. So that's what occurs in the first half of the pregnancy. And what happens in the second half of the pregnancy, when the demands are the more, and there will be the lipolysis. All the stored fat will be converted into the free fatty acids, and that is the lipolysis. In the same way, the protein breakdown will be there, that is the proteolysis. In the same way, the glucose which is stored in the liver in the form of the glucogenesis will be converted to the glucose in the form of glycogenolysis. In the same way, neoglucogenesis, sometimes with the amino acids and the fats also will convert to the glucose, that is the neoglucogenesis. So all these alterations will occur in the second half of the pregnancy. In the first half of the pregnancy, the glucose is stored in the liver, the glucose is stored in the muscle, the glucose is stored in the adipose tissue. The main purpose of these changes is to ensure adequate nutrition in the form of the glucose to the growing fetus during the times of the plenty as well as the times of the scarcity. At the same time, the times of the plenty, that means in the prandial period. The times of the scarcity, when the mother is sleeping. So during most of the nocturnal times. At the same time, the metabolic demands of the mother also need to be met. So that is the reason. So usually the pregnant mother, they gain weight to the tune of about 8 to 12 kgs during the pregnancy. So another reason for the increased incidence of the type 2 diabetes in India in this GDMC is after the pregnancy, after the delivery. So almost these 8 to 10 kgs has to be lost. But most of our Indian population, so they keep on gaining the weight even after the delivery also. So that could be another reason for their obesity, especially the visceral adiposity, and later time they convert into the type 2 diabetes. The fetus is dependent on the maternal supply of the nutrients for all its requirements. So the fetus, the bridge between the mother and the fetus is the placenta. So the placenta, what are the structures that traverse through the placenta? Your glucose will traverse, your amino acids will traverse, and your ketone bodies will traverse. Insulin won't travel, and then glucagon won't travel. So whatever the fetus requires, the fetus gets the glucose, amino acids, and the ketone bodies through the placenta. The nutrients from the maternal circulation cross the placental barrier and reach the fetus. This process is primarily dependent on the maternal fetal concentration gradient of the nutrient in question. When the mother is having hyperglycemia, so obviously when the fasting blood sugar of the mother is 140, so the same glucose will traverse to the fetus also, concentration gradient. In the same way, when the mother's postpartum blood glucose is 250, So the same glucose will traverse to the fetus through the concentration gradient through the placenta. So what will happen to the placenta? In the fetus, the fetal pancreas starts producing the insulin just by the 8th week of the pregnancy. So 8th week of the intrauterine life itself, the fetal pancreas starts functioning. So it keep on secreting the insulin. So what is the main stimulus to release the insulin from the pancreas? Glucose. So when the fetus getting more and more glucose from the mother, so what will happen to the fetal pancreas? Keep on secreting the insulin. So there will be the hyperinsulinemia even in the fetal pancreas. In the same way, the mother already had the hyperinsulinemia because of the insulin resistance. So there is a mismatch between the insulin resistance and the insulin secretion. If you think that this is the insulin resistance, the insulin production also must match that, not to have the hyperglycemia. Again, the insulin resistance will go up as the pregnancy increases. The duration of the pregnancy increases, the insulin resistance will go up. From the 5th month, this much of the insulin resistance. In the 6th month, this month. 7th month, this month. So what will happen to the normal mother, a non-GDM mother? So the pancreas also secreting the more and more insulin, that is the matched, and you don't get any hyperglycemia. So what will happen in the GDM? The insulin resistance will be more, insulin production is low. So there is a mismatch between the insulin production and the insulin resistance. So that's how you get the maternal hyperglycemia, chronic maternal hyperglycemia, and you consider it as a GDMs. So this already I told you, the glucose, amino acids and the ketone bodies, they traverse through the placenta to the fetus, whereas the triglycerides not possible, insulin and the glucagon also never crosses. So this is the see, in the anabolism, you know the insulin is a good anabolic hormone. So insulin promotes glucose entry into the muscle, insulin promotes glucose entry into the liver, insulin promotes glucose entry into the fat, that is the adipose tissue. So in the anabolism, the insulin, so there is insulin resistance, hyperinsulinemia will be there, and hyperglycemia. What happens in the catabolism? So you will have the lipolysis and you have the ketogenesis, and there will be the hypoglycemia also. So this is accelerated. So both the things will be increased. So it's a combination of the facilitated anabolism and accelerated starvation as the gestation increases. So the main hormones involved here in the early pregnancy are the estrogen and the progesterone. They do their level best not to have the hyperglycemia. Whereas in the second half of the pregnancy, you will have the placental HPL, and you have the prolactin, and you have the progesterone. So they are not good for the glucose. They cause more and more insulin resistance, and they cause more and more hyperinsulinemia, and finally they cause more insulin resistance and more hyperglycemia, that is GDMs. So in the early pregnancy, these two hormones won't cause any increase in the insulin resistance. These hormones cause hyperinsulinemia by promoting the beta cell hyperplasia and increased insulin release. So more insulin release means your glucose will be under good control. During the early pregnancy, the first phase of the insulin secretion found to be augmented when compared to the pre-gravid state. However, the second phase secretion remains unchanged. So here you should know the insulin release. So insulin released in the two phases, the first phase and the second phase. So in the first phase is a very short, immediate after the food. So that is how in the normal individuals won't have any postprandial hyperglycemia. So what will happen immediately after the food? The insulin will release more. So once the insulin is released more means your blood sugars will be under good control. So what happens in the type 2 diabetes? The first phase of the insulin is lost. So once the first phase of the insulin is lost means there will be more and more postprandial hyperglycemia. The second phase of the insulin is also blunted. It is a delayed. It's a deranged. So what will happen to your random blood sugar? Because the second half of the insulin release is also released, not is disturbed. So there will be more and more postprandial, and even the random hyperglycemia is also will be there. So that what happened in the diabetic individuals. In the diabetic individuals, postprandial blood sugar will be high. The random blood sugar will be also high. The postprandial blood sugar is high because of the first phase of the insulin is lost. The second phase of the insulin is blunted. That is the reason your random blood sugar also will be very high. So in the early pregnancy, what will happen in your first phase? It will be good. Even the augmented, it is increased. So you won't have any postprandial hyperglycemia. So this is the early pregnancy. See, hyperinsulinemia increase the insulin sensitivity. So insulin acts on these three organs. One is the liver, the center one is the muscle, and then it is the left one, right one is the adipose tissue. So facilitated anabolism. The main purpose is to prepare the mother for the increased energy demands expected during the later pregnancy. During early pregnancy, energy demands from the fetus are relatively low since the linear growth is not as rapid as it will be subsequently. So in the first half of the pregnancy, good story. So mother is good, fetus is good, requirements are less. So there will be good hyperinsulinemia. The first phase is good, second phase of the insulin release is good. So that is how most of the people, they won't have any hyperglycemia during the first half of the pregnancy. Now the second half of the movie, what will happen? Since insulin sensitivity is normal or raised during early pregnancy and insulin secretion increase, GDM is rare during this period. So this is the second half. Second half is very not good, bad as far as our GDM is concerned. See, after 20 weeks of the gestation, the placental hormones start playing an increasingly important role. So what are they? Most important one is the HPL. So the main placental hormone contributing to the insulin resistance is the human placental lactose. What you mean by the insulin resistance? The insulin is not making the glucose to enter into the hepatocytes, or insulin is not making the glucose entering into the muscle or to the adipose tissue. So that the glucose entry into the hepatocytes or in the muscle cells or in the adipocytes is disturbed or deranged because of this insulin resistance. Other hormones involved are the prolactin or the cortisol, progesterone and the growth hormones. These are the counter-regulatory hormones. All of these hormones antagonize the effects of the insulin and bring about a state of the physiological insulin resistance. So what are all the good effects of the insulin lost? Even though there is more and more insulin production. So here you should remember that it is not the total absence of the insulin. Insulin is producing. In fact, there is hyperinsulinemia. But whatever the insulin, what is the higher quantity of the insulin production is also there. But that insulin is not quality insulin. Even though the quantity is there, the quality is weak. So that is how the insulin resistance is playing a major role. That is all because of the HPL, prolactin, cortisol, progesterone and the growth hormones. So the increased levels of the placental hormones cause the insulin resistance. So there will be the facilitated diffusion following a meal. Higher blood glucose levels enable the free diffusion to the fetus to meet these increased demands. See, the first phase of the insulin is lost. The second phase is blunted. So there will be the hyperglycemia. So once there is a postprandial hyperglycemia in the second half of the pregnancy, so what will happen to the fetal glucose? That also increases because of the concentration gradient. So in the second half, accelerated starvation in the fasting state. See, high levels of the free fatty acids and the ketone bodies to provide fuel for the mother so that the glucose is spared for the fetus. So in the mother, what will happen? There will be the lipolysis, there will be protein breakdown. So that is how the true GDMs, you don't expect the obvious weight gain in these mothers. So you are expecting 8 to 10 kgs, but you are not, the increase in the body weight is not that much, maybe because of this lipolysis and proteolysis. So this already I told you, the first phase of insulin response. Insulin sensitivity during the different stages of the pregnancy is reduced. In most women, the beta cell can compensate for the increased insulin resistance of the pregnancy by hyperplasia and the hypertrophy. So in the beta cell hypertrophy will be there, the beta cell hyperplasia will be also there. The third trimester fasting insulin levels are twofold higher than the pre-pregnant levels in the normal pregnant women. If you check the insulin levels, they are very, very high. This results in the fasting blood glucose levels that are 10 to 20 milligrams lower than in the non-pregnant state. So because of the higher insulin levels, the fasting blood sugars are at a lower level. This already I told you, even in the last trimester. So GDM develops when the beta cell is unable to compensate for the increased insulin resistance. Why does the beta cell fail to adapt? Maybe because of some genetic factors. Maybe the chronic insulin resistance antedating the pregnancy, especially in the obese women or the women with a strong family history, or the subclinical inflammation. So now the inflammation, it is the vascular inflammation or endocrine inflammation. So what are the risk factors? So Mrs. C, a 22-year-old primey, 156 centimeters tall and weighs about 51 kgs, BMI 20. She has no family history of the diabetes. What is the normal BMI for Indians? Is it 23 or 25 normal BMI for Indians? 25 to 30 is overweight, more than 30 is obesity. Is it right for Indians? Up to 25 is the normal. So this is wrong. So up to 25 is the normal is the wrong. 25 to 30 is the overweight is the wrong. More than 30 is the obese. That is also wrong. That is your Addison's and the Davidson in the Western population. For the Indians, up to 23 is the normal. 23, BMI 23 is the normal. 23 to 25, some people say 25, some people say 27, that is overweight. And beyond 25 or beyond 27 is the obese. Okay, so for a given BMI, we are having the more fat. For a given BMI, we are having the more vascular inflammation. So that is the reason the BMI levels have cut down for the Indian population, not only for the Indian, Southeast Asians. So what is the risk of developing the GDM? This girl, 22 years, BMI 20, that means normal. Lean means less than 18, 18.5 is the lean, 18.5 to 23 is the normal. No family history of the diabetes. So what is the risk of developing the GDM? Is it mild risk or moderate risk or a severe risk or no risk? No risk is wrong. No risk is wrong because she is an Indian. Yeah, mild is the right. Okay? Mild risk is the normal. Is the right answer. Because all Indians, whatever may be her BMI, whatever may be her age, whatever may be the family history, they are at risk of getting the GDM. That is a big take home point for all of you. No Indian is of no risk. Either mild, moderate or severe. So now the risk, what is the risk here? See, 33-year-old, 2 miscarriages in the last 3 years. Earlier delivered a baby weighing 4.1 kg, not 41 kgs, 4.1 kg. BMI 31, not both her parents have diabetes. So what is the risk of developing? Is it high risk? Is it very, very high risk? Very high risk. Because here what are all the points? The age more than 30 years. Already past bad obstetric history. And then overweight. The BMI 31 is obese, very obese. And then the strong family history. So risk, so that is the risk. See the earlier case, mild risk. Here, very, very high risk. See, unfortunately, most of the people we are seeing at this juncture right now. See, these type cases are very, very few in the society right now. So such people are very, very high in society right now. So these are the risk factors. So the obesity, not the BMI 25 and metabolic syndrome. Sorry, right? BMI 25 is the right answer for the obesity here. And the metabolic syndrome, you know what you mean by the metabolic syndrome. Diabetes is the first degree relatives, the strong family history of the diabetes. A previous GDM is again a big risk factor for the GDM in the next pregnancies. Okay. Previous macrosomic body. What is the macrosomia in the Indian population? Is it 4.5 kgs or 3.5 kgs? Yes, 3.5 is the right answer for us, whereas 4.5 is the right answer for Western population. A member of high risk ethnic group. All Indians fall in this category. Age more than the 25 years. Even PCOD, is very, very common nowadays. Previous polyhydramnios and previous unexplained perinatal loss or birth of a malformed infant. So these are all the risk factors. See, we see a lot of the risk factors in our population. So most of the people are obese, strong family history, because the number of the type 2 diabetes are increasing like anything. I told you, 7.7 has gone up to 10.4 crores in Indian population. So previous GDM is common, previous macrosomic bodies. So Indians, age more than 25 is very, very common nowadays. PCOD is common. So these are very high risk factors to get the GDM. So what are the implications of the GDM? What are the maternal implications and the fetal or the neonatal implications? So in the maternal implications, we will have the preeclampsia, polyhydramnias, the operative delivery, okay, perineal trauma, maybe shoulder dystocia, etc. Risk of the future diabetes. This is a very, very common. Here the risk of the future diabetes not only to the mother but also to the fetus. So the mother is at risk of getting the type 2 diabetes, and the most of the people they turn to be normal. 95% of the people, this GDM, they turn to the normal after the delivery. And 5 to 10% they continue to have the hyperglycemia, and about 75% of these mothers will turn to the type 2 diabetes in the next decade. So that is the reason what advice you give to the GDM mothers after the delivery. So they have to follow up. Follow up is very, very important. First follow up 6 weeks after the pregnancy. Second follow-up, 6 months after the pregnancy. Third follow-up, 1 year after the pregnancy. And next, every annually. So that's how we have to advise these people. Otherwise, most of the people I see in my practice with the fast history of the GDM, they never told that the follow-up is very, very important. So after delivery, they didn't check the blood sugars at all, and after 4 years or 5 years, they directly land up to me with a fasting blood sugar 200 and postpone blood sugar 400. So if you take an history, there is a history of the GDM delivered somewhere. So the 6 weeks follow-up, 6 months follow-up, 1 year follow-up, annual follow-up, they lost. So this is a very, very important. See, because identification of the diabetes in the early time will definitely helps them to avoid the long-term complications. That is your metabolic memory. So what you mean by the metabolic memory? So you have to diagnose the diabetes in early time, and you have to give a good prescription for the diabetes, and you achieve the euglycemia so fast so that you can avoid the long-term complications. Even though the control is not good afterwards, the chances of having the long-term complications is very less in those people who are having good metabolic memory. So it's our duty to to identify the diabetes at an early age group. So the fetal and neonatal complications. See the fetal macrosomia, here 3.5 grams kgs, birth trauma, prematurity, RDS even without the prematurity, respiratory distress syndrome, that is your surfactant deficiency. So the surfactant deficiency, the what treatment you are given for surfactant treatment? You give the steroids. So steroids means what will happen to the blood sugars? It also will go up. So you have to increase the doses of the insulin. That is one clinical point. So whenever you give the steroids in a pregnant woman, especially for the GDM population, to avoid this respiratory distress syndrome in the neonates or the infants, so you have to increase the doses of the insulin. So you otherwise what will happen after giving the steroids? The sugars will go up. The mother will land up with the UTI, or mother will land up with some infection or pneumonias, etc. Neonatal metabolic complications like hypoglycemia, so very, very common. Why hypoglycemia? Because of the placental removal. So when you are clamped the umbilical cord, what will happen to the blood in the fetal part? So there will be the maternal hyperglycemia will be there in that blood. Though this maternal hyperglycemia will stimulate the fetal pancreas to release more and more insulin. So there will be hyperinsulinemia in the fetus. So once the uterine, your umbilical cord is clamped, so there is no further availability of the glucose to the fetus. So there is a fetal hyperinsulinemia, but non-availability of the glucose from the mother will land up with the hypoglycemia. So this is a very, very important. So nowadays the neonatologists they take care of this hypoglycemic part. And hyperbilirubinemia that not occurs within the hours, maybe the days to the weeks to get the hyperbilirubinemia because of the breakdown of the RBC. Hypocalcemia maybe because of the hypoparathyroidism, and polycythemia maybe because of the hypoxia. Intrauterine hypoxemia will lead to the polycythemia. So these are very common. Obesity and the diabetes in the latter. These children, so these children is at chances of getting the childhood obesity and also type 2 diabetes maybe at the age of 18 years or 20 years. Nowadays, a lot of the people studying the Sri Chaitanya Narayana, they are the type 2 diabetics with the childhood obesity. If you take an history of the GDM, yes, they are the offsprings of the GDM mothers. So this is very important. The obesity, childhood obesity and the type 2 diabetes occur in a younger age group. So earlier, if you get the diabetes less than the 20 years, it is mostly type 1 diabetes. Now in India, the common type of the type 2 diabetes, we see between the age group of 15 to 20 years age group is type 2 diabetes, early onset, not the type 1 diabetes. See the congenital malformations, they are extremely uncommon in the GDM. Why? Because all organogenesis will occur in the first half of the pregnancy. So in the true GDM, the congenital malformations are very, very rare. Whereas in the pre-gestational diabetes, yes. So since it usually develops in the late pregnancy, long after the organogenesis is complete, risk of the malformation is similar to that in the woman with the pre-existing diabetes if the GDM is diagnosed in the first trimester. So identify the GDM. So that's what you are all doing good. In the first antenatal visit itself, you are doing the blood sugar test. So that is a good boon to avoid the misdiagnosis of the diabetes. So the macrosomia baby is one whose weight is above the 90th percentile for the gestational age. LGA, that is the large for the gestational age. 3.5 kg seems to be the reasonable for the Indian people. Two types of the macrosomias, symmetrical and asymmetrical. Infants of the mothers, the GDM have the asymmetrical, with the abnormal thoracic and the abdominal circumferences, which is larger than the head circumference. Organomegaly is also present, or hepatomegaly, etc. In untreated GDM, the risk of macrosomia is as high as the 40%. So this is the macrosomia. High risk of birth trauma, shoulder dystocia, clavicle fracture, humerus fracture, brachial palsy, etc. So avoid them by going for the CS. Increase the risk of the C-section, increase the risk of the diabetes in the later life. So this is the Pedersen's hypothesis. The maternal hyperglycemia leads to the excess exposure of the fetus to the maternal glucose, the fetal hyperinsulinemia and excess growth. That is the cause for your macrosomia. Why the macrosomia? Because of this. So the more the maternal hyperglycemia, so the more the maternal hyperglycemia means again the concentration gradient, more glucose to the fetus. So there will be the fetal hyperinsulinemia, and no, insulin is anabolic hormone, you know that. So the insulin, what will happen? There is a good hormone, insulin. So in the fetus, so that causes more and more growth of these cells. So there will be protein synthesis, there will be lipogenesis, etc., leading to the macrosomia. This is the Pedersen's hypothesis. So the concept is further refined by the Frankel, who added a potential role of the other nutrients, the mixed nutrients in the fetal overgrowth. Here the mixed nutrients means your amino acids and the free fatty acids. Other metabolic problems in the neonate hypoglycemia, it is due to the abrupt cessation of the delivery of the maternal glucose to a neonate, already explained. So neonatal hypoglycemia is inversely related to the maternal hyperglycemia at the delivery. So the more the maternal hyperglycemia, the neonatal hypoglycemia. Other metabolic problems in the neonate, polycythemia, RBC breakdown, this also I told you. Respiratory distress syndrome, surfactants, stillbirths. They are rare in the GDM, is greater than in the general population. Majority occur even in the absence of the congenital malformations. Depends on the severity of the diabetes and adequacy of the metabolic control. Rate of stillbirth is equal to that of the general population. Good control of the diabetes levels in the mother can reduce all the adverse outcomes in the GDM. This is one of the cornerstones of the modern GDM management. So good control of the glucose with your diet, with your exercise, and with your, especially the upper body exercises. And then with the metformin in some cases, and the insulin. Okay. And whereas in Africa they use the glibenclamide also. But we don't use the glibenclamide in Indian patients. But in South Africa and the African countries in the GDM, they use a lot of the glibenclamide. That is the only sulfonylurea which does not cross the placental barrier. All other sulfonylureas, they cross the placental barriers. Risk of the future diabetes in the offspring. So the infants of the mothers who had diabetes during the pregnancy have a higher risk of developing the obesity, metabolic syndrome, IGT or type 2 diabetes in the future. Offspring of the women with GDM are at 4 to 8 times higher risk of developing the type 2 diabetes. Nowadays, maybe 40 to 80 times because of the pampering in the houses, single child. GDM and the risk of the future diabetes in the offspring. GDM and risk of the metabolic syndrome in the offspring. The preeclampsia. See, the diabetic pregnancy is associated with a higher rate of the hypertensive complications than the normal pregnancy. Risk of preeclampsia is increased in the GDM. So at a later time I will also talk on hypertension induced pregnancy. Okay, we will talk at a later time, preeclampsia, etc. What about the risk of the future diabetes? Following the delivery, diabetes persists in the 5 to 10% of women diagnosed to have the GDM. That depends on the amount of the insulin resistance they are having it. 35 to 60% of women with GDM will develop the type 2 diabetes within the 10 years. So this is very, very common. Maybe in Indian population, maybe less than the 10 years also is common. Maybe 4 to 5 years, they turn to the type 2 diabetes. So the GDM means future type 2 diabetes. Conversion to the diabetes occurs more frequently and faster in high-risk ethnic groups such as the Asian Indians. In the same way, the pre-diabetic converted to the diabetes is also very high in the Asians. In the Western population, only 14% will convert pre-diabetics to the diabetics. Whereas in India, 84% will convert from the pre-diabetics to the diabetics. So what is the epidemiology? The prevalence of the GDM varies according to the population studied. The global prevalence is 1% to the 15%. The prevalence rate of GDM in population is proportional to that of the diabetes and IGT in that particular population. So in India, so we are having high cases of the diabetes and IGT. So our prevalence is very, very high. So if you see the things earlier, 80s only 2% the prevalence of the GDM in India. 90s it is 7%. In 2000s it is 14.5%. Now I think somewhere between 25 to 30% the prevalence of the GDM in our Asians, especially our Andhra population. So the GDM prevalence is very very high. Now I have few questions to you. So it's a big public health importance. GDM has a public health importance far beyond its immediate effects on the mother and the child. Proper management and follow-up of the women with GDM and their offspring has the potential to prevent the diabetes in 2 generations. So both the mother and the offspring. So please answer this question. The first recorded description of gestational diabetes was made by? Yes, right answer is the Benedict. So she first described this gestational diabetes. What about the Carpenter and Coaston? They have the criteria. What is the Pedersen's? That is your hypothesis. So facilitated anabolic medicine. The term gestational diabetes was introduced by O'Sullivan. O'Sullivan, he first introduced this term. Which of the following molecules can freely traverse the placental barrier? Only glucose here. No insulin, no triglycerides, no glucagon, only glucose. Glucose and amino acids. Early pregnancy. All the following are true except early pregnancy there is beta cell hyperplasia, hypertrophy, yes. Second phase insulin secretion is increased. Insulin sensitivity is usually unchanged, yes. There occurs a reduction in the fasting plasma glucose levels. B. Bombay. Second phase of the insulin secretion is not increased in the early pregnancy. Most important hormone contributing to the insulin resistance in the pregnancy. Calcutta. Human placental lactose is the right answer. Which of the following is not a risk factor for the GDM? See again Calcutta. Family history diabetes is a risk factor, marked obesity is a risk factor, PCOD is a risk factor, age above 25 years is a risk factor. Here the C is the right answer. Cutoffs for the macrosome in India. B. Bombay 3.5 kgs. Which of the following neonatal complications likely to occur days to the weeks as opposed to the hours? Hypoglycemia within hours, hypercalcemia within hours, polycythemia within hours. Yeah, A. Amlapuram, hyperbilirubinemia. Which of the following may not be an important cause of stillbirth in GDM? Not a cause for stillbirth in GDM. Congenital malformations, excess fetal growth restriction, all the above are equally important. GDM. Why not A? Amlapuram. A is the right answer here. Congenital malformations not in A, GDM, not in GDM. It is in pre-gestational diabetes. So what are the take-home messages? The pregnancy is a diabetogenic state. GDM results when the beta cells is unable to adapt to the diabetogenic milieu of the pregnancy. Prevalence of GDM is very high to the tune of about 25% right now. Diabetes in pregnancy is also the serious consequences to the baby as well as to the mother if early detection and the appropriate treatments are not offered. So thank you very much for your patient hearing.